I'm chair of the Committee on Alcoholism and Drug Abuse, and I'm the sponsor of the bill that will deal with managing the antibiotics that are increasingly being used in livestock, and practice we need to change. I'm the sponsor with State Senator Brian Kavanaugh, and welcome to this briefing. Before we begin, I'd like to go around the room and have people introduce themselves.
Sure. My name is Lucy Shepard. I'm the Director of Policy of the Commission on Rural Resources. We're chaired by Senator Rachel May, and then our co-chair is in the Assembly, Assemblyman Angelo Santa Barbara.
Hi, I'm Nick Venezia. I'm from Senator Boyle's office.
Hi, Sarah Manuela. I'm with Senator Boyle's office also.
Jan Dorman from Senator Stavisky's office.
I'm Nick Guile. I'm the Assembly Member Rosenthal's Legislative Aide.
I'm Isabel. I'm Senator Gallivan's Legislative Fellow.
I'm Dennis. I'm from Senator Mayer's office.
Jeff Palmer, New York State Department of Ag and Markets.
Kelsey Dorado, Department of Ag and Markets.
Charlie Krasinski, I work for Cornell University.
Zoe Nelson, Cornell University as well.
Rogan Zangari from Linda Rosenthal's office.
Danielle Segal from Senator Kavanaugh's office.
Stacey Arell from Malcolm and Ross.
Blair Horner, NYPIRG.
Rob Zangroff, also NYPIRG.
Chuck Bell, Consumer Reports.
Jean Halloran, Center for Food Safety.
I'm Lance Price from George Washington University.
I'm Saul Hymes from Stony Brook University and Stony Brook Children's Hospital.
And I'm Michael Hansen from Consumer Reports.
William Wright, Lead Media Coordinator, Radio TV of the Assembly.
Excellent. Thank you so much. So we are recording this so that we can distribute it to members who could not make it, since we are in session in a couple of minutes. So, I mean, this is particularly important because of the growing threat to public health from emergent strains of antibiotic-resistant bacteria, also known as superbugs. And, you know, people generally hear about antibiotics when they're prescribed one when they were a kid, and when they were an adult, they just say, give me some antibiotics. Just prescribe it. You don't have to see me. And unfortunately, some doctors do agree with that. And there are far too many prescriptions out there for humans. For animals, it's a different story. They are often given antibiotics prophylactically. So they're not sick, but to prevent them from getting an infection or some other issue, they are given antibiotics. The result has been that infections, bacteria, are now resistant to all the drugs that we have. I don't know that labs and pharmaceutical companies are producing more different antibiotics, but the ones we have now are increasingly not working. And that spells death for some. And by 2050, we think we're all going to be in real danger if we don't address this issue. So that's what this bill aims to do, and we're going to be hearing from the experts who have worked on this issue, studied it, and are real experts on it, to see how we can combat this problem and hopefully pass the legislation that will enshrine in law the way to combat this problem. So thank you very much. I'm sorry. Okay, are we waiting for Kavanaugh?
If you start for now, I'll let you know.
Okay, so we have several wonderful participants. Dr. Lance Price, founder of GW Antibiotic Resistant Action Center. Dr. Saul Hymes, Pediatric Infectious Disease Specialist at Stony Brook School of Medicine. And Dr. Michael Hansen, Senior Scientist at Consumer Reports. And Jean Halloran, Center for Food Safety. So maybe you'd like to begin.
Do you want to go first?
Okay, go.
Thank you.
Thank you.
Do I do it from here, or?
Yeah, you can sit here.
Okay.
So
You could pass the people or pass the mic.
Well, I mean, I think so. We have so many people coming and showing up. Maybe we should sit. Okay.
Can everyone hear me? Okay. All right. Thanks. Thanks very much, Senator Rosenthal, for having me, and to Senator Kavanaugh in absentia as well. Just out of curiosity, was anyone who's here now at the press briefing earlier today? Few people. Okay, I'll try not to completely repeat myself. So as was said, I'm a pediatric infectious disease specialist and medical director for pediatric antimicrobial stewardship at Stony Brook Children's Hospital on Long Island in Suffolk County. And I'm an assistant professor of clinical pediatrics at Stony Brook University Renaissance School of Medicine, and have been a member of the New York State Task Force on Antimicrobial Resistance and Stewardship that did have a subgroup devoted to antibiotic use and problems of antibiotic resistance in animal agriculture and sort of the One Health kind of side of things. And it's in these roles that I have seen every day and sort of deal with the issues of antimicrobial resistance and what it means. To review a bit sort of from the clinical and human medicine side of things, which is sort of what I'm here for, antibiotic resistance is actually pretty straightforward, and it's something that a lot of patients and a lot of people really seem to get lately. The number of times I actually get questions from patients when I prescribe an antibiotic about, oh, isn't it bad to take one because it might not work the next time? It's really filtered down a lot into popular consciousness. And essentially every single time a bacteria is exposed to an antibiotic, whether it's something we take, whether it's something an animal is given or eats in their feed, or is given by mouth, every dose exposes bacteria that are in or on that person or animal, mostly healthy, colonizing bacteria that can become pathogenic if they get into the wrong place. Every time those bacteria are exposed, they have the potential to become resistant to that drug. It's selective breeding, sort of unintentionally, that we're doing when we give these antibiotics. It's not new. Alexander Fleming, when he accepted the Nobel Prize for medicine for the discovery of penicillin in the 1940s, had warned about careful and judicious antibiotic use, because even then they were already starting to see resistance. And he knew that antibiotics wouldn't last forever, and so wanted people to save them for when they were needed. And so this has been going on for some odd on 80 years. Just to come off of something that Assemblymember Rosenthal had said, if you actually look at how long it takes for resistance to develop after an antibiotic is introduced clinically on a timeline, while it took some time for some of the first antibiotics to lead to resistance, all of the newest ones, resistance is basically there essentially when they hit the market or within months to a year after. So while there are some new antibiotics that are coming down the pike, that's not really a solution long term, because the bacteria move quicker than we do. And so what is coming down the pike, and what's really already here, is this post-antibiotic era. Those of us who treat patients are already seeing infections that are resistant to all antibiotics. Thankfully in pediatrics we see it less than in adult medicine. They see it a lot more. Out of curiosity, how many people in the room garden or do any kind of plant sort of stuff at home or for fun? Anyone? Or have handled roses in a bouquet or anything like that?
I've done that.
So pretty much everybody probably. So one of the first cases of penicillin use was a gentleman who had pricked his thumb on a rose thorn, got a staph infection from it. They gave him penicillin. It started to get better. This was back in the days when penicillin would still work for staph, which it doesn't anymore, hasn't for decades. Started to get better. They actually ran out of penicillin, because this was really early in the history of antibiotics, and he got the staph, came back, spread through his bloodstream, made him septic, and he died. So imagine if you're handling a bouquet and you prick your finger on a rose thorn and 2 weeks later you're dead. That's sort of potentially what we're talking about. That's the direction things can go. The latest CDC data, 2.8 million people are sickened, and 35,000 die from antibiotic-resistant infections each year. In terms of the deaths, it's the equivalent of, say, Elmira or Ithaca or Rome, New York, in terms of number of people who die, and it's also about a third of the population of Albany. And every year, the equivalent of the entire population of Brooklyn gets sick from them. Those of you who were at the press conference heard me tell a story about a sort of somewhat altered version of a patient who is a kind of example of a recent patient who I've had who I encountered with a resistant infection, and so I apologize for the repeating. But we'll take, say, we'll call her Wendy. This is an 8-year-old girl who is healthy, has never taken antibiotics before, gets brought into her doctor's office saying it hurts when she goes to the bathroom. Her doctor takes a urine sample, diagnoses a urinary tract infection, which is really a minor problem. I won't ask people to raise their hands, but I assume a number of people in the room have either had or known people who've had a urinary tract infection. Doctor reassures the parents, starts Wendy on a few days of a reasonable oral antibiotic. Over the next 2 days, she gets sicker, she gets fevers and shaking chills. The culture, meanwhile, grows out an E. coli that's resistant to all our oral antibiotics, so she can't take anything by mouth to treat it. This is something that during my training I had really never seen, and unfortunately we see a lot now. So she's now sicker. This now is more than just a bladder infection, it's an infection in her kidney. She gets admitted to the hospital. It's the infection sort of spread up the ureters because the bacteria is just growing nonstop. She does get IV antibiotics. They start to work. She has to get anesthesia to have an indwelling catheter placed in her arm. She has to go home with a home care nurse. She misses school. Her parents miss work. She does get better, but this is for something that really should be a nuisance that, you know, is now an extensive drain on our healthcare system and really not fun for her. But this isn't the end. So a number of kids get these kinds of UTIs because they have issues with their bladder anatomy or their urethra anatomy, and it turns out that, that she has that also, though there are plenty of kids who get UTIs without that. And while you can try and fix the problem, and urologists do as she gets older, it's not perfect. She keeps getting urinary tract infections. Every time we treat one, the bacteria causing the next one, which has already started out resistant to a lot, gets a little bit more resistant. We're just continuing to apply that evolutionary pressure on the bacteria. Similarly, every infection, the next one's just a little bit more severe. It has to be treated just a little bit longer and a little bit more time in the hospital because she's got ongoing kidney damage from these infections. So now she's 15, she comes into the hospital, now with the bacteria not just in her urine, not just in her kidneys, but in her bloodstream. She's septic, the infection has spread that quickly. They start antibiotics, the same ones she got last time, and she's not getting better. So they call me, the consultant. Yay, I'm supposed to march in and pronounce that I have a drug that I can treat her with. But I don't have one because the cultures are now growing a bacteria that is resistant to all of the antibiotics that we have, IV or oral, and her infection is untreatable. And so over the next day or two, basically delirious, surrounded by machines, she dies with her parents around her of a UTI that we could not treat, of a urine infection, of something that, you know, it's really like cranberry juice should treat. This isn't a hypothetical, I've changed details, but this is representative of cases that I've taken care of. I did not go into medicine to have to tell parents that I have nothing to offer their child, especially not with regard to antibiotics for infections, but this example was not the first and it won't be the last. What else are we going to have to tell our patients that we can't offer them? So how many of you have had or known someone who's had, say, a hip replacement or surgery on a bone that involved a plate or any sort of metal or anything like that? So anyone known anyone who's had heart surgery? So you can forget about those. The infection risk with those is too high. Our cardiac surgeons are going to go out of business, orthopedists are going to go out of business because the risk, if we have an infection that you can't treat after one of those surgeries, the risk of death becomes too high to do those surgeries. I mean, tonsillectomies, you're doing surgery in the mouth in a place filled with bacteria, so they usually get antibiotics after those, and that's out the window. Organ transplants, anything where you have to suppress somebody, cancer treatment, bone marrow transplants, all of those also go out the window. I mean, the thing that killed the initial when we were in the first years of treating cancer, the thing that killed patients was not the chemotherapy, it was the infections that they got from the chemotherapy. Or I'm sorry, rather it wasn't the cancer, it was the chemotherapy and the infections they got from the chemotherapy. We actually couldn't really successfully treat cancer until we had antibiotics that could kill the bacteria that they got, as well as chemotherapy drugs. So the list goes on. I mean, there's tons of modern medicine that basically becomes impossible if we lose the ability to treat infections. And so the only way to prevent this, since you've heard a couple of us talk about how new antibiotics aren't really the solution long term, is to slow the rate of resistance. And we have to use less antibiotics. We're working on that in people. That's only part of the picture. We need to use less in animals as well. We know that there's data that the antibiotics we give animals wind up other places, that the bacteria that are resistant to those antibiotics that are in animals wind up in humans. The CDC estimates about 20% of the 2.8 million antibiotic-resistant infections are in origin from animal antibiotic use. So that's about 600,000 people. It's the population of a couple of middle-sized cities upstate, say Buffalo, Rochester, and Syracuse combined. So it's not an insubstantial number. This bill is a really great way for New York to continue to lead in healthcare, as it has been, and to make sure that antibiotic use in animals is as judicious as possible and as judicious as we try to make it, or continuing to try and starting to try more to make it in humans, so that my patients and my own family and all of you and all of your families and constituents will have those available for years to come, those antibiotics. Thank you.
Hi, I'm Lance Price. I'm a molecular microbiologist, so I'll be sort of speaking from that perspective. But when I hear Dr. Hymes talk, I have to speak from also as a father and a brother. So I have a 7-month-old, and thinking about Wendy's story just gives me chills. I mean, can you imagine your child or niece or nephew, or just losing them to something that was treatable just a few years ago, something as benign as a bladder infection? It's just, it's shocking. And thinking about the parents pacing in the hospital room floors as people struggle, doctors struggle and fail to find an antibiotic to treat that child, and hearing them cry. I mean, it's just like heartbreaking. As a brother, I have to tell you about my sister. So my sister was diagnosed with bone cancer 3 years ago. She found out when she stepped out of the tub and her femur broke, and she had a pathological fracture. Went to MD Anderson, and she was getting amazing care. MD Anderson is just a phenomenal place. Not to take away from Sloan Kettering, of course, also a wonderful place. But in her first 4 rounds of chemo, she got 3 bacterial infections. So, chemo just, you accept the collateral damage that it's going to knock out your body's cells and make you vulnerable to infection. So she was vulnerable to infection. 3 infections in 4 chemo rounds. Thankfully, none of them were drug resistant. And so the antibiotics saved her life. So she's alive today. She's minus 1 leg, but she's amazing, still her vibrant self, because of the great care that she got at MD Anderson, and because those antibiotics worked. And so this is about protecting those life-saving drugs. So I think we have to face this market failure that we have right now. So the reason that we have these bacteria that are resistant to everything we have is because of a major market failure. Drug companies make so much more money off of drugs that people take every day for the rest of their lives, that these drugs that a fraction of people take for just 10 days just don't recoup the kind of, or don't bring in the kind of income that they want to make. And it takes a long time to recoup the $1 billion that it takes to introduce that antibiotic. And so we've got to do everything that we can to protect them because of this market failure, because drug companies are sort of bailing out of this. But there's also other economic forces that are playing here, and I think of it as quarterly thinking, right? So everybody's sort of thinking quarterly, how much money can I make in this quarter, not thinking about long-term sustainability of that drug. So I can treat a few people, or I can treat a lot of animals. That's a pretty good way to make more money in a quarter. But but that kind of quarterly thinking does not just apply to animal production. It also applies to human medicine, and we see this, throughout medicine, but really, we've noticed quite a bit in urgent care where, there's this changing environment of how people seek care today, right? So we go in, we don't go and see Dr. So-and-so that we've known since, we stopped seeing our pediatrician. This is just somebody we don't know. We're paying at the door to see them, and so we feel like a paying customer. They're afraid of the competition in the marketplace, and so, the currency is antibiotics a lot of times, right? Let's write this antibiotic. Because it's hard. I would love to hear about, the burden of keeping the records that you have to take. I know there's some burden there when you only have 18 minutes with a patient, probably, right? And so what we're seeing in urgent care is just writing lots of prescriptions, and so that is fueling part of this problem. But the other thing that's fueling this problem is the millions of pounds that we're using in animal production, and we're using them. Of course, sometimes they're being used appropriately to treat sick animals, but you also, up until just recently, when we finally withdrew the label that allowed them to be used for growth promotion, the industry was using antibiotics just to make animals use their feed more efficiently, to grow faster. But now what we're trying to do, what we're trying to do here in New York is try to close what I think is a major loophole, which is routine disease prevention. So not treat a sick animal, not treating the animals around a sick animal, what we call control, but just giving animals antibiotics based on a clock or a calendar because we know they're going to get sick because of the way we're raising them. That's what we're trying to stop. And we're trying to stop antibiotics that we use in human medicine, same classes of antibiotics, from being used that way. And that's, from my perspective, a complete abuse of antibiotics. Because when you give an animal antibiotics, those antibiotics, it's not like a homing missile. You can't say, go to that infection and kill that infection, right? You don't get to talk to the animal and the antibiotics. You fill that animal with the antibiotics, and they perfuse all the tissues of that animal. And they put selective or evolutionary pressure on all the bacteria that live in and on them. And like us, they have trillions of bacteria living in on them, and some of them have the potential to cause disease in us. So you're leading to this evolution of drug-resistant bacteria that can then spread to us through the food supply or through the environment and cause infections that he can't treat, right? And so that's what we're battling. And so some of the bacteria that we see that you're probably familiar with are Salmonella. You maybe heard of Campylobacter, so those cause diarrhea. Diarrhea is no big deal most of the time, right? You're uncomfortable for a few days, use a lot of toilet paper, you're better. But sometimes, if you have a weak immune system, or if it's a particularly aggressive strain, it can get into the blood, right? So you can have what we call an invasive infection. Those are deadly infections, and you really need the antibiotics at that point. Well, if those bacteria, those Salmonella and Campylobacter, become resistant to the antibiotics that we use in animals, and those happen to be the same drugs that he tries to treat the infection with, then that treatment can fail. And when you have a blood infection, you have a very short window to save that patient's life. And so we're talking about risking people's lives for this. And I think it's kind of intuitive to think about the risk to those classic foodborne pathogens like Salmonella and Campylobacter. But we've also learned about Staph aureus, so staph infections, and urinary tract infections today. So staph infections, my own research, I'm a molecular microbiologist, so what that means is we collect samples, sometimes from all over the world, from meat, from people, from animals, and we pull the DNA out of them, and we sequence the entire genomes. So we were one of the first groups to do this in large scale. And we study the evolutionary history of these bacteria and try to understand how the bacteria over here are related to the ones in the animals are related to the ones in the people. And what we showed very clearly is that there are strains of livestock-associated methicillin-resistant Staph aureus, or MRSA, that clearly evolved from antibiotic use in pig production and now spill over to people, sometimes through the food supply, very rarely, but largely through direct occupational exposure. So this is an occupational risk. We've also shown through the same types of studies that there are strains of E. coli that are in our food supply, largely coming from poultry, that cause urinary tract infections in people. And they're resistant to the same drugs that we use in animals. And so those antibiotics are not going to work in people. That's what Wendy had, right? Wendy had a urinary tract infection. So we are, through this, abuse of antibiotics, I would say, I'll use that term, I know it's controversial, we are helping to evolve drug-resistant bacteria that can infect us. So I think, we have to recognize that there's a synergy between the antibiotics that are being overused in human medicine and the antibiotics that are being overused in animal production. Anytime that you're using them just to satisfy a patient or a customer or to make your production more efficient, I consider it abuse. But those two work synergistically to fuel this crisis that we're in. And we all have to take our responsibility. We can't point fingers at one industry or the other. We have to accept our responsibility, can't shirk it, and say, all right, yeah, we're gonna be better stewards of these antibiotics. We're gonna track the drugs that we use, and we're gonna report it so that we can keep track of this and we can protect these antibiotics for future generations. I love this bill. This bill, it's hard to read a lot of legislation. This took me no time at all, right? I've read it a couple of times. It's 2 pages. It's very straightforward. It allows veterinarians to still treat sick animals. You just can't use them based on a clock or a calendar to prevent diseases that you're causing. And so I think it's a wonderful bill. I really appreciate the leadership from Senator Kavanaugh and Assemblymember Rosenthal, and I'm really glad to be here today. This is the kind of leadership we need across the country. So thank you.
Hi, my name is Michael Hansen. I'm a senior scientist at Consumer Reports. We're located in Yonkers, and my training is I'm an evolutionary biologist and an EE ecologist. So the first thing I'd like to just say is whenever you use antibiotics, you're selecting for resistance, right? That's so the more you use, the more selective pressure you're putting on, not only to select for antibiotics that are of a similar type, and that's cross-selection, but we now know that antibiotics that the resistance elements can all combine together in plasmids, and there can be 8 or 9 different resistance genes. So that means anything you're using, even something like tetracycline, might be selecting for resistance to all these other antibiotics. So the problems of cross-selection and co-selection make it critical that we need to be minimizing our use of antibiotics. And I would also point out, before I get into some of the Consumer Reports, what they've done on this topic is 2/3 of all medically important antibiotics being used in the United States are used in animals, not people. So yes, we do need to reduce antibiotic overuse and misuse in human medicine, but we also need to do that in agriculture as well. And Consumer Reports over the last 10 years, we've done a number of studies looking at, for example, ground beef, chicken, ground turkey, and shrimp, and they clearly show that there are a lot of disease-causing bacteria in our food supply. For example, our study on beef found that 100% of the samples were actually contained bacteria that could make you sick, cause urinary tract infections and blood infections. Now, a significant proportion of the pathogens that we're finding, these bacteria that we're finding in food, are superbugs, and those are defined as bacteria that are resistant to 3 or more classes of antibiotics. So even though you might be using an antibiotic in animal ag and it's not the same one that's used in human, if it's in the same class, then that means resistance to one will lead to resistance to the other. So, and what we found this significant proportion, so for example, 14% of our ground beef samples, 14% of the shrimp samples, 83% of ground turkey, and 57% of chicken samples were contaminated with superbugs. And it also turns out that when you look more carefully, the production method, so that means if you use a production method that doesn't use antibiotics, a label that says no antibiotics, or organic, or for beef you have grass-fed, those production systems were less likely to contain superbugs compared to the conventional production systems. So I'll leave copies, but in this article, as part of a 3-part series, this Making the World Safe from Superbugs, the summary data is here. And for example, if we look at beef, the conventionally produced ground beef twice as likely to be contaminated with superbugs as sustainably produced. And it was 3 times as likely to be contaminated as grass-fed. So that means 18% of all the conventionally produced ground beef had superbugs. 9% was the figure for ground beef that was produced using these more sustainable methods, and 6% was for the grass-fed. So those are very clear differences that show that the production method can have an impact on the occurrence of superbugs that are in the food we eat. We also did a nationally representative survey in 2018, and that found that 78% of the respondents agreed that meat producers should stop giving antibiotics to animals that aren't sick. We also found that 59% of the respondents would be more likely to eat at a restaurant that serves meat raised with no antibiotics. So what this is showing is that there's actually, consumers are concerned. When they buy in the marketplace, they tend to buy labels that are labeled as no antibiotics or organic or these other things, and when they go to restaurants. So this is increasingly showing that's what the market wants. So the producers that are moving in this direction, that's creating a market for them. And I'd also like to end by saying this is an issue not only here, but it's an issue globally. I'm very involved with, there's this global task force on antimicrobial resistance. We're trying to come up with some global rules. And even the World Animal Health Organization agrees, for example, that medically important antibiotics should not be routinely being used for disease prevention purposes. So this bill will still allow doctors and vets to prescribe medically important antibiotics for disease treatment and disease control. It just says you can't use them on a regular basis for prevention because that is exposing too many animals and is basically selecting for these resistant bugs. And that's why we strongly support this bill. I think New York can be one of the leaders in this area, particularly if we get it right. And I should also say it's very important in this bill that there's also have this reporting mechanism so that we already have a national reporting mechanism. It isn't as good as we'd like it. And they are trying to make that better by getting us data on individual species and not just the amounts that are being sold. But if you want to make a rational look on what the impact of your legislation is, then we need to know how much is actually being used and what production methods will help lead to reductions. And to do that, we need data requirement. So I do think both parts of this bill are very crucial, and we strongly support it. And we'd also like to thank Senator Kavanaugh and Assemblywoman Rosenthal for sponsoring this bill, and we hope it gets passed.
Hi, I'm Jean Halloran, and I'm from Center for Food Safety, and I just wanted to talk briefly about a project that a number of our groups have been involved with. Consumer Reports, the Antibiotic Center at GWU, Natural Resources Defense Council, and PIRG, of course. We've been doing this study called Chain Reaction now for 5 years, surveying the major fast food chains, McDonald's, Burger King, KFC, on what their policies are on antibiotics in the food that they buy and serve. And it's been very interesting because over the 5 years, there's been a really big change in chicken. These fast food chains have have decided that they could ask for chicken raised without antibiotics, and the industry has evolved considerably. So we're now to a point where something like 95% of the chicken produced in the United States is raised without medically important antibiotics. That doesn't mean they get zero. There's other classes of antibiotics that aren't used in people that they do get. But they've figured out how to raise chickens without the drugs, by and large, most of the time.
Less than 4% in 2012, right? And
Yeah, yeah, it's been a huge change in the industry. But we haven't seen that kind of change yet in beef and pork and dairy. And it's very important that we see it, because even with the change in chicken, we still have 2/3 of all of our antibiotics going to animals, basically mostly healthy animals, not sick people. And the bacteria don't discriminate. They travel around among all of us. There aren't strong barriers. So, but we think that there actually, with this bill could be a big opportunity for New York State. New York State is a huge dairy state. I believe we're the fourth largest dairy producer in the country. Not everybody knows, but spent dairy cows frequently end up in McDonald's burgers or somebody else's burgers. And McDonald's, among others, but McDonald's in particular, which is the biggest beef buyer in the nation, has launched a program to source their beef to cows that are raised either entirely without or with reduced or minimal levels of medically important antibiotics. And they've started this process, and it's going to kick into full gear in a year or so. So we think that this bill, which is really important from a public health perspective, could also really be good for New York State in terms of what happens to its dairy cows after they're not producing milk anymore. So, thank you. And now, Blair, do you want to take questions?
I think if any people have questions of the group, they should feel free to ask them. Anybody? There must be somebody. All these people here, there's brain power. Nobody has a question.
We've put you to sleep.
Is any, do you want to go into any more detail, Gene, about the reporting requirements? That seems to have been an issue. In some of our conversations, people have brought up the reporting requirements in the bill. But the reporting requirements were designed to be similar to parallel the reporting requirements that the FDA is asking vets to meet on their use for antibiotics when they're using it for disease prevention. Now, this bill would say no more use for disease prevention, just use for control and for treatment of sick animals. But the reporting requirements are designed to follow that model, follow that style, so that hopefully veterinarians wouldn't have to at least learn a new method of reporting.
I think it's worth actually going through what's required, if you guys don't mind. I mean, it's total number of food-producing animals provided with medically important antimicrobials. So, pretty straightforward there. The name of each antimicrobial, the species of food-producing animals that were provided with each medically important antibiotic, the quantity of each medically important antibiotic provided to each species of food-producing animals, the number of days, so how long are they treating them, the dosage, so what's the dose, the method for providing each medically important antimicrobial. Is it water, food, injection? The purpose, what are you trying to treat? right? The disease or infection, if any, that was intended to be controlled due to the provision of these antibiotics. That's pretty straightforward stuff. And is this very different from what you have to report? I mean, I know you're not treating multiple kids most of the time, right?
Right. No, I mean, it's, I will say...
In one species, usually.
Usually one species, yeah. I mean, occasionally the odd chimpanzee, no, just kidding.
You want to pull the microphone over?
Oh, yeah. So, yeah, no, I mean, yeah, it's, I mean, the lessons, I think, from the medical antimicrobial stewardship world are valuable, because this is ultimately, it's about behavior change. I mean, it's about getting all of us who are used to doing things one way to change the way we're doing things. And there is some extra work sometimes involved in tracking things. It involved, at least in our hospital and a lot of children's hospitals and adult hospitals, sometimes creating an extra system or co-opting an existing system to track things if we hadn't been previously tracking them. But it actually, from a reporting and tracking standpoint, has actually ended up being super interesting and pretty helpful for everyone involved, because some of the folks who kind of complained about it, it turned out weren't actually big users, and were able to kind of point that out and show that and say, hey, you guys thought all of us surgeons were really bad, but look, we're actually not. And so, you know, took pressure off of their back. And then the groups that were overusing, because we all care about this stuff, vets, doctors, none of us want to be doing something that's not indicated. It was eye-opening, but people sort of saw, hey, actually, wow, I didn't realize we were using antibiotics as much as we were. Thank you for this data, and you know, let's figure it out, and figure out a way that we can change this. And so, you know, it's sometimes in the medical world, it's sort of seen as the antibiotic stewardship folks like me are the ones who come down with the iron fist and say, this is how you can use your antibiotics. And I think, you know, one could look at a bill like this as saying that, but I don't think really that's the aim. I think it's, you know, certainly the hope is that this becomes, especially with the tracking of the data, a collaborative process and kind of an integration of what's going on with animals with what's going on with people, and what some of the existing plans in the new budget for human antimicrobial stewardship are, to really have it be this sort of collaborative process, to kind of benefit everybody. I mean, even benefit the animals. It's not great if farmers' animals are dying from resistant infections either. So.
Yeah. The other thing I'd also like to point out is this is national data. I don't know it for New York State, but 75% of all the medically important antibiotics being used are being put in feed. That is already has to be reported with a veterinary feed directive. So vets are already doing that. The FDA has realized that there's this loophole with injections and some of this over-the-counter stuff. They're in the process of actually making that going to be reportable and have to come under the control of vets as well. And you can never say when that's going to happen with the FDA, but it is part of their 5-year plan, and the meetings we're having within them telling us they're going to have something out by the end of the year. So all the, for the vets that are concerned with, oh yes, there's antibiotics that are over the counter that farmers can just go get, FDA realizes that's a problem, that loophole is going to be closed. So the other data requirements is you're really just talking about some of the injection stuff and water, because the vets already have to keep data on for the veterinary feed directives with all this information. So for 75%, they're already doing this. So I don't see that this would be a very onerous thing. And in fact, since it's ultimately probably is going to be required federally, you're going to get a jump on it.
Did that provoke any interest among those along the wall to raise any other issues? I mean, obviously we're trying to do this so that people can be persuaded that we can figure out a way to deal with this problem. This 20% of the...
Does anyone have any information on countries that have restricted the use of antibiotics in animal farming?
It's funny. I was just thinking about the Danish experiment.
Thank you.
Yeah. So, well, I mean, just putting context to the antibiotic reporting piece. So, in Denmark, I think it's I can't remember what year it was, but they banned all.
2010.
2010 was the original ban. So to eliminate antimicrobial growth promotion, so feeding animals antibiotics to make them grow faster, but also routine disease prevention. That cut total antimicrobials just about in half. And then what you saw was therapeutic use started sort of crawling up over the years. So it wasn't a spike immediately afterwards. It was just this slow crawl up. And so what they did was they implemented something called the yellow card system. So this is a place where soccer is really popular, right? So, you know, you're in trouble when somebody shows you a yellow card, you get sort of, that's your warning, right? And so the yellow card system was for particular pig producers. Remember, Denmark's one of the world's largest pork exporter. So despite this ban on growth-promoting antibiotics and routine disease prevention, they still compete on a global market. But so some of the pork producers, if they were exceeding standards and how many antibiotics they were using, they would send an agent out, an extension agent out, to help them figure out what was the problem. So it wasn't like, oh, you're just abusing these antibiotics. Oh, clearly there's some health issue on the farm. We want to help you solve that. And so data like these can actually improve the welfare of animals and improve antibiotic stewardship at the same time. So I think it's just transparency, and I think coming back to the earlier point about the physicians who were being inappropriately blamed for overuse, the transparency allowed them to see, oh, actually you guys aren't as bad as we thought. You're still jerks, but, you know, just kidding, that's just a surgeon joke. But the problem's over here, so let's figure out how we dial that back. And so, you know, I think this can't hurt good producers. Right? This won't hurt good producers, responsible producers who are raising animals in a way that promotes their health. This shouldn't be an issue at all. And so it actually should level the playing field with the bad players. And then it sets a model for the rest of the country that hopefully this will become adopted by the rest of the country at some point.
Yeah, and I'd also say that internationally we have both the World Health Organization, which a couple of years ago put out a document on antibiotic use in agriculture or in food animals, and they made very clear medically important antibiotics should not be being used for growth production purposes, period. And even the World Animal Health Organization, OIE, within the last year, they have passed resolutions literally saying that medically important antibiotics should never be given in water or feed for disease prevention purposes. So we have the World Health Organization saying this, we have the World Animal Health Organization saying this, and other countries. Part of the reason that antibiotics were going up in Denmark and other places in Europe after they got rid of the growth promotion ban was that some of this stuff that they were calling therapeutic was really disease prevention. Well, regulations are coming into the EU this year that will also say no use of antibiotics for disease prevention. And at the global level, it's in terms of growth promotion, we now have over 110 countries that have banned that. And then all these other countries, including places like Chile and Bangladesh and Indonesia, have not only banned antibiotics for growth promotion purposes, they've also banned them for disease prevention as well. So we're seeing other countries, not just in Europe, but even in what's called the developing world, realizing this is a problem as well and taking action. And those numbers get bigger every year. And in terms of the antibiotic use data, OIE has this program where there's now, I believe, 170 countries, but countries are now starting to give this information in waves for how much is, first is how much is being sold, then if they can figure out how much is being used, and ultimately if you can figure out what the dose equivalents are per each animal so that you can calculate how much antibiotic is being used to produce a given quantity of meat. And for example, in Europe, it's far lower than the U.S., although we do come close to some of the levels in Italy and elsewhere. And that you need data for. And so the rest of the world is starting to do this. OIE thinks it's a good idea, and they're trying to get all these countries to do it. And we should be leading that. We shouldn't be trailing all that. We should actually be leading that. So we've been trying to get the U.S. to take these better positions internationally, and then at the various state levels, like New York State or California, to try to get them to move in these directions that all these global agencies agree is the right way to go. And again, it's not just the World Health Organization for people that like them. It's the animal folks. It's OIE is saying this as well. So that's part of the reason why these bills are coming in here, because we're seeing this action here and we're seeing it globally. And we would like to see the U.S. and New York State being leading in these areas and not following.
Well, we've come up on our first hour. If anyone has any last questions.
So I wanted to bring out a little more about how consumers are exposed to superbugs. I think, Dr. Hymes, you had said that about 1 out of 5 infections come from the food supply chain itself, so like 600,000 out of the 2.8 million every year. And so we've had these multi-state outbreaks of involving superbugs. Could some of the panelists just say a little bit more about what's the risk to consumer, both when they visit a healthcare institution or when they eat food that has superbugs in it?
Well, I think I touched on this in my comments, but basically what can happen is that if you have individual companies that are using, lots of antibiotics, routinely using antibiotics, then they can select for or lead to the evolution of drug-resistant pathogens in their animals. Those animals then go into the slaughter facilities, and when they cut open those animals, they release those bacteria, basically, that are in the guts. Those can contaminate the meat, and then the meat is packaged up and distributed to grocery stores, right? So, and my eyes are pretty good, but I can't see bacteria, right? And so you bring these into your house, and yeah, you can cook away the bacteria, right? So if you cook your chicken all the way through, you're not going to get sick from the bacteria on that piece of meat. But when you handle that piece of meat, when you brought it into your house, when you open that package, you've just contaminated your hand. Who knows what's dripping off of that onto the cutting board or onto the countertop, right? And then you open the cabinet door, you contaminate that. You turn on the sink to wash your hands, you contaminate that. You pump the soap, you contaminate that. You wash your hands, you sing happy birthday twice, and you shut off the faucet and you've just recontaminated your hand. You go to make a salad. So that's how you spread these bacteria around. And my wife is also a microbiologist, and we're just like always, hey, and as careful as we are, you're going to find bacteria from meat in our kitchen because we prepare meat regularly. And so they get around. They're small. You can't see them. It's hard to wash your hands that often. And so there's always going to be foodborne disease, but what we're trying to do is prevent the organisms that cause that disease from being resistant to the bacteria to the antibiotics that we care about. And so it's really overuse leading, and then occasionally you have the overgrowth of these really bad pathogens, contaminate the food supply, and then those get distributed around. And then our tracking system's not great, right? So we can sometimes, we have these P codes, processing codes on these packages of chicken, so you can sometimes trace them back to there. But beyond that, back to the farm is almost impossible. And so it's really hard to intervene in these outbreaks. And so the best thing to do is prevent the bacteria from becoming resistant. The other thing that we can do is do more to prevent pathogens from colonizing our animals, but we're not doing a very good job of that either.
Yeah, one other thing I would add to that is it isn't just the pathogens. You're selecting for resistance, and that resistance can be in benign bacteria and then move into the pathogens. So it might even be in benign bacteria that's in that meat. You eat it, and that can then move into a pathogen that's in your gut. So the disease-causing bug doesn't have to come from the meat. The actual resistance elements, which they now know are swapped around between bacteria very readily. So you can actually have it in the huge quantity of, we can now through whole genome sequencing, previously the only bacteria we could study were the ones you could culture. So that would be maybe a few dozen when we know there's tens of thousands. Well, now they can start to look for the antibiotic resistance genes and see them moving around in the environment in all these benign bacteria until they ultimately make it up into a pathogen that we care about. So we should be concerned about not only the antibiotic resistant pathogens, but the resistance elements themselves, because they can move around from benign bacteria to pathogenic ones. And so that's why we have to actually stop the production and spread of resistance elements so that they don't make it into pathogens.
Thank you, panel. It's 3:30. We all have to move on to the next thing anyway. If people have any questions, of course, that they think of after they leave here and they wish they'd have asked it, feel free to either contact me and I can get the information to the relevant person, or Assemblywoman Rosenthal or Senator Galvin. Thank you, panel.
Thanks for coming.